This is the Physical Activity Researcher Podcast, a podcast for researchers of sedentary behavior, physical activity, and sports. Join for a relaxed dialogue about research design, practicalities, and, well, anything related to research. Learn from your fellow researchers useful and relevant information that does not fit into formal content and limited space of scientific publications. And here is your host, researcher and entrepreneur, Olli Tikkanen.
Welcome everyone. Before introducing guest of today's episode, I would like to note just few things. Physical Activity Researcher podcast is committed to promoting equality and diversity in all its activities, including selection of guests. We have limited resources to scout all great researchers from different groups of people, so if you know someone who should be as a guest in the podcast, please ask this individual to contact us directly. As another thing, I would like to ask for your help. Being able to deliver this podcast to you, my audience, is based on how many people find, start to listen and follow this podcast. So I would really appreciate little help promoting this podcast. You can do this by subscribing, following the podcast on Twitter, retweeting tweets sometimes, and maybe even giving a good rating if you liked an episode. And now it is time for the actual show and introduction of our great guest of today's episode. He is a medical doctor with PhD in public health. He has received his academic training in Finland, Switzerland, and Sweden. And currently he works as an assistant professor at Florida International University College of Medicine. He has also worked in non-communicable diseases in Argentina, Colombia, and Paraguay. He is an active member of the American Public Health Association in both the physical activity section as well as the epidemiology section. Ladies and gentlemen, please welcome our guest, Dr. Noel Barengo. Welcome, Noel.
Yeah, thank you. Thank you, Ollie, for the introduction. It's a pleasure to be here and to participate in the podcast.
Yeah, really honored to have you here. So you have a really interesting international background. Would you like to tell about your medical and academic journey this far?
Well, it has been a long journey. I grew up, I was born and grew up in Switzerland, in Lucerne, and grew up in Zurich, and where I started my medical studies. So I studied half of the study there, 3 years. And then I went actually to Kuopio and I studied, finished my medical studies at the University of Kuopio. Now it's the University of Eastern Finland, where I graduated from medical school. And then I sort of tried to avoid like clinical work and so started to a master's in public health with the professor at the time, Professor Aulikki Nissinen, who was well known for the North Karelia project in Finland. And my other mentor was Jaakko Tuomilehto, who was another well-known famous epidemiologist in the field of chronic disease. And then I started to do a PhD under their supervision on physical activity and all-cause mortality and hypertension and different kind of outputs or long-term endpoints of chronic diseases. After graduating from the PhD, then Jaakko Tuomilehto, he recruited me to a European diabetes prevention project called DE-Plan, which was about diabetes in Europe, changing, reducing the incidence of diabetes by lifestyle interventions like physical activity and nutritional habits. And at that time point, I was living already in Riga in Latvia with my first wife. And so I worked from there on the European project, coordinating it. Later on, then I went to Spain, to Madrid for a postdoc and working at the University La Paz in Madrid. And from there, as I liked always South America, ended up in Argentina for about 4 years or 3 years, where I worked as consultant at the Ministry of Health, helping with the physical activity guidelines. I also worked as a teacher at the university, teaching medical students health promotion, public health. From
Mm.
there, I ended up in Colombia, and where I lived 4 years with my current wife. And there I worked as a consultant at the Ministry of Health. Helped them developing the physical activity guidelines, as well as the diabetes prevention and screening guidelines. And while being in South America, I also worked a lot with other countries like Chile, Paraguay, and helping basically a lot in diabetes prevention and physical activity. And about 4 years ago, I received a job offer to come to Miami to the International University of Florida, Florida International University, and where I have been working ever since the last 4 years. So mainly now it's a teaching position, so I'm teaching clinical epidemiology, research methods, and evidence-based medicine, and I also got involved in the American Public Health Association. So I'm the chair elect of the physical activity section, as the organization has a lot of different sections. I think there are about 20 sections, and I'm naturally involved in the physical activity section, and I'm setting up a diabetes interest group. I'm also
Mm.
in the American Diabetes Station now, chair elect of the epidemiology and public health section. So that's more or less about my international journey. So somehow I end up in the United States.
Yeah, that was there was many countries in that, and I've been also going places quite a bit. How do you feel? Where is home, or is the home just the place where you happen to be at the moment?
Actually, it's probably the latter. I mean, I feel comfortable where I am now. Florida's nice. I mean, despite the hurricane seasons and the heat, I mean, it's usually in summer it's between 34 and 40 degrees. In winter, it's between 15 and 25.
Mm.
I mean, my family is comfortable here. The schools are good where we are. I'm good at my work. I feel confident. I mean, I feel good. There's a lot of things to develop professionally, and so I'm still learning a lot of things. But of course, it's not Europe. I mean, what I miss in Europe, I mean, the cities are different, the culture is different. So it's always nice visiting Europe. And I haven't been to Finland actually for about 8 years. So it would be nice to spend some time again in Finland, or especially in Kuopio, and
Mm.
to see my one of my favorite. I like hockey, so I like usually Kalpa, so I'm a hockey fan. So
Yeah, yeah, yeah. And you know well enough that the summer is the better time to visit Finland than the winter.
it is, but sometimes it's nice to have some snow, cold, and ice, but not maybe 6 months. So it could be nice to be there like February, March for 2 or 3 weeks going skiing. But
Yeah,
I mean,
yeah.
I mean, every country I think has its benefit and its nice part. I mean, Finland is beautiful, Switzerland is beautiful too, and I've seen a lot of really nice countries, and you get to know them when you live there. That's probably the easiest way.
Yeah, I fully agree with you. So, with all this very interesting background being in different countries, what is your main interest at the moment?
I have two main interests. I mean, the interests have shifted a little bit through my career. When I started with physical activity research, so in cohort studies using the FinRisky and FinMonica studies. So that gave me like an insight in physical activity from the epidemiology, public health point of view. Then as Jaakko Tuomilehto, who recruited me for the diabetes activity, he works strongly in diabetes. So I ended up for a very long time working in diabetes prevention and screening, which is still one of my main activities. Recently, then in my time in South America, I basically worked in physical activity research, like in more in population implementation of physical activity guidelines, the public health aspect, the epidemiology aspect, together with diabetes screening and prevention. And physical activity is one of the most important to risk factor of type 2 diabetes. So it fits perfectly. And due to my teaching assignments, as we teach our student research methods, they have a 2 month rotation with us. They have to choose projects using some existing databases. So that means that they do research on the cancer registry. We have data from national surveys. So from that point of view, I started to do a lot of cancer and health disparity research as well with my students. So assessing differences of race on mortality outcomes in different cancer patients, but basically a lot of different projects in the field of public health, but still with my main focus, physical activity and type 2 diabetes.
Mm. So you have been working a lot relation to diabetes. Could you tell how important the physical activity is in the prevention, and what kind of different aspects are important in physical activity?
In basically the two main risk factors of type 2 diabetes is like obesity or overweight and physical inactivity. So physical activity helps in both, helps in preventing or delaying type 2 diabetes, as well in patients with type 2 diabetes. It's increases their endpoints, increases their control. This is because physical activity has an important impact on the glucose level mechanisms and the control of glucose in the blood. It drives the glucose from the blood into the cells, so reduces the glucose levels. And it has a lot of other, it has an impact on insulin resistance and many other metabolic elements. So, what is recommended, I mean, for health, for been shown in the prevention of type 2 diabetes. If you're like 30 minutes per day active of moderate intensity, then this is basic enough to have a good impact on health and preventing diabetes. For instance, the diabetes prevention study that was carried out in Finland, or the diabetes prevention program in the United States, and many other diabetes prevention programs, they usually show that with that doses of physical activity, 30 minutes per day, every day of the week, and moderate intensity, that this is one of the two components that help to reduce or delay type 2 diabetes. The other component is like a nutritional advice, so weight loss, but usually don't give only one. You have to combine them. So it's a energy balance. I mean, if you move more, you eat a bit more. If you move less, you have to eat less to have still a equilibrium, like not a positive energy balance. Because if we eat more than we spend energy, then we go up in weight, and if we spend more energy than we eat, then we go down in weight. Actually, it's very simple mathematics, but it's not that easy to implement. But basically, with half an hour of moderate intensity activity, which is that if you practice this, you can still talk to someone, but you can't sing anymore. That's more or less moderate activity.
Yeah.
This podcast is sponsored by Fibion, a research device that has been shown to be valid in tracking sitting, standing, physical activity, and energy expenditure. Furthermore, Fibion has been shown to be valid categorizing physical activity into light, moderate, and vigorous intensity. In addition to scientific accuracy, Fibion provides automatically produced and easy-to-understand reports for research participants. Get scientific validation and learn more about Fibion at fibion.com/research.
And how do you see the importance of different intensities of physical activity? So if we have quite unfit person, it's quite difficult to do moderate intensity for long durations before getting actually really tired, or that it starts to affect. But kind of lower intensity you can do more, but it has different physiological effects. So how do you see the importance of different intensities?
Uh, the intensity are important. I mean, the main problem, specific in the US, is that people are not active at all. So we cannot ask people to become from unfit or like sedentary lifestyle to go to moderate, which is a bit complicated because you first have to motivate them that they start moving in basically. So there's some studies, and we currently doing some data analysis, checking like the impact of mortality, the cardiovascular mortality in people that are not meeting the guidelines of health now moderate intensity, but who meeting, they move at least something, and it has been shown that they basically do also better. So even if we start making them moving from no physicality to somehow physicality, at least a low intensity, but they move it has a health benefit. But the other thing is the guidelines basically also show that you should engage at least twice per week in muscle strengthening activities. And this can be done pretty easy from home. I mean, there can be some push-ups, can be like jumping jacks. I mean, there are different kind of exercise you can do, and they have some benefits as well. So if you combine it or have low levels of aerobic physical activity, but do twice per week some muscle strengthening activity, it has a benefit as well. So they do better than people who do not do anything. But I agree that the most important thing is to break the circle that people start to be at least somehow physical active. And that's probably the biggest challenge we have at the moment.
Mm. And you mentioned the muscle strengthening exercises. Is there different mechanisms at play when you compare, for example, moderate intensity physical activity and then type of resistance training? That what do these affect, these different modalities?
That's actually an interesting question. So I'm not 100% sure. I need to go probably read a bit more about the differences. I mean, both exercise increase the heart rate, have a lot of beneficial um, impacts on thrombolytic factors, on insulin resistance by their impact they have in their body. So the different forms. I mean, muscle strength activity, they train certain parts of the body, more the muscle strength and not the aerobic capacity. So probably maybe there's some differences, but as both bases have been shown to have some benefit. The other thing is if you increase like from two times or three times muscle strength activity to 4 or 5 times every day, there's not that much additional benefit anymore. The same if you go from moderate to vigorous physical activity, aerobic activities, there's not that much benefits that you get additionally. So it's really enough for the regular people to be moderately active, and you don't have to run a marathon or be vigorously active. So even with low doses or with somehow some levels of physicality, you get probably a lot of benefits.
Hmm. So better to do just more moderate intensity activity than vigorous intensity activity in relation to type 2 diabetes risk.
Yes, I mean, not only for type 2 diabetes risk, the same in regard risk of hypertension, of cardiovascular disease mortality, cancer, even cancer mortality and all-cause mortality. So moderate levels are enough for health purposes. But then, I mean, for athletes, it's different. The guidelines all say that if you do vigorous physical activity, then 75 minutes per week is enough. But probably most people do vigorous physicality. They training certain disciplines like tennis or soccer or something, and they usually have automatically more than 75 minutes. But for health purposes, moderate intensity is enough. It's sufficient.
Hmm. Do you know why is it like that? Because kind of the vigorous is giving a stronger stimuli for the body, but is it that if you are unfit, the moderate is already giving enough of stimuli for adaptation? That why the vigorous doesn't give you more advantage?
It's probably, I mean, it's what we've seen. It's sort of a curve that is have a steep increase if you start at physical activity, get to moderate levels, and then it flattens a little bit out. So you still have some benefits if you compare it between moderate and vigorous physical activity, but the benefit gained is not as big as from low levels to moderate than comparing with moderate to vigorous. So the biggest benefit you get from changing from no visitor to moderate, maybe it's a sort of it's maybe not a linear dose response relationship, but more like a curve. So you get until a certain level, if you get physicality, then you get all the benefits, and the more you do, then it doesn't give anymore that much. So probably you're feeling the capacity which you can achieve with physical activity. The problem is then if starting from vigorous level or more or very vigorous level, you also could have some increase in risk. So what you should recommend people when they start the physicality, there's, I mean, two kind of screening what you should do or could do. I mean, the first one is you can check like on the health behavior cycle. There's something called how people change behavior, like a Prochaska model. So we evaluate first where people are. Are they in the phase that they do not want to be physical active? Are they in the phase that they are thinking to be maybe active? Or in the phase that they're already have already taken a decision they're gonna be physical active? So to help them evaluate where they are, because people who are like in the I don't want to be physical active, the thing we can do with them is giving them information. We can explain them why it's important to be physical active, the benefits they will get, so motivate them, and to tell them that if they like to be active or start, they can approach us. People who are in the phase like pre-contemplation, meaning that they're thinking to be physical active, with those we can start to work on a plan and motivate them, because I mean we all know the most difficult thing is breaking the cycle. I mean, if you're sedentary, that we start once we start, it's much easier. So that's one of the approaches. The other one is we probably need to screen, because we cannot people who have cardiac heart diseases tell them they have to go running immediately without having some sort of checkup. So there's some checklist that identifies if people have certain risk factors, for instance, if they move, if they have chest pain, or some factors that show that they may have a heart disease, or if they have hypertension and a certain age limit, then usually before they engage in moderate intense activity, it'll be good to having like the heart checked. And but for the regular, for the lay person, a younger adult, and without any risk factors, there shouldn't be any problem. So there shouldn't be any check. You don't need probably a checkup in order to be physical active. And this is probably to avoid like sudden death, or some people usually you see like read some newspaper headlines that a guy ran a marathon and he died sudden death. These are basically people who have had some precondition, and
Mm.
that's why they had some adverse events. And but this is like vigorous activity, so moderate activities are pretty safe. But some people, maybe it's not recommended to moderately active due to some basic diseases they have. But that's why it's good to have sometimes a screening.
Mm. And how do you see the prescription of physical activity? It's well known that it improves most of the risks for chronic conditions, but how could we improve the effectiveness of prescription in
Mm.
different countries?
I like the physical activity prescription idea. And I know that, I mean, it started with the green prescription in New Zealand many years ago. I know that Finland has implemented, I think the UKK Institute, the leadership on that, and it has been used in primary healthcare as well. In South America, the American College of Sport Medicine, they have started a program called Exercises Medicine. And when I lived in South America, I used the program. We were training physicians in the prescription of physical activity. So I've held workshops like in Paraguay, in Uruguay, in Argentina, Colombia, in many countries about it. And I think it's a good concept. It depends how the training is. I mean, you need to train the physicians or the healthcare personnel. In the Americas, basically the program targeted physicians or specialists, and but I think it's much more. You should target a whole group of healthcare workers, because the physician doesn't have that much time. If you have 10 or 50 minutes for patients, it's not enough to go through all the physical activity part. So you need to work with nurses, maybe the psychologist, with nutritionists. So creating a group that you divide the task for the physical activity prescription. I think the prescription works and it motivates the people, and systematic reviews have shown that by prescribing physicality, they increase the amount of physicality they spend. It has been well perceived, and the concept is, I mean, people when they go to a physician or to a doctor, they usually expect they come out with a prescription. And if you just give advice, you should be physically active and no prescription, they maybe used to be disappointed. But now they have an individual description how to practice physical activity, how many times, what disciplines they could do every day, what can be done. But in regard to prescription, to be you ask how to be more efficient. I think we need to train even more or better the healthcare personnel. It includes the primary healthcare physicians. For instance, Finland has like I think 20,000 physicians, and half of them are primary healthcare, more or less. So I think they play important roles. So we have to train them about the importance of prescribing physical duty, that they reorganize the time that they can spend with the patient, that they know that probably have to first evaluate where the patient is in the healthcare, a health behavior change cycle. The same we do with actually patients who like to stop smoking. And then you need to have probably some guidelines who can you prescribe physical without any other additional tests. So I wouldn't prescribe to physical directly to patient who have a underlying coronary artery disease and hypertension at 60 years old without first having some his heart having checked up and maybe having a treadmill test to check his fitness levels,
Mm.
and then to adapt this to his physical duty prescription. So I think it's all about training and reorganizing maybe the healthcare system, the timing that the working groups in, as in some countries, like I remember in Finland, you're very well organized. I mean, the at the primary healthcare center, you work in groups. A physician works with a nurse, with a nutrition psychologist. In other countries in South America, it's more like sort of separated. There's a physician and there's the nurse, but they haven't really started to work as teams. And I think in the prescribing visit, it's really important that you work as in healthcare as teams. You delegate the task so everybody does what he can best. I mean, even physical duty educators or physical duty specialists, they're probably the best ones to guide the patients through how to practice physical duty and what to do. Probably better than physicians. A nutritionist gives the best advice on what to eat. The psychologist probably he or she could take care of removing the barriers to start with practicing physical activity. So I think that could make it even more an impact even more. But I think it's all about training and start to train healthcare personnel.
Mm. Yeah, so basically training of healthcare workers and doing teamwork would be important. So how do you see the, like you said, physicians are busy. Who should be the one taking care of the exercise prescription and the behavior change? Should there be a role specific for this task?
Um, it depends a little bit on the different healthcare systems and the role of the physicians, because in some countries, people, the patients, they do not believe that much the nurses or other healthcare personnel. They're very much focused on the physicians. In other countries, it's not that emphasis. The roles are not that different. I mean, there's not this hierarchical principle. I think the physician has to make a decision, takes the responsibility, and whether the patient can start physical duty. He can do the first screening. I mean, he can check like whether the patient fulfills the criteria that he can practice physical duty without any problem or moderate intensity, and probably tell the patient, urge him to be physically active, as probably has an impact on patient's behavior, maybe more than other healthcare personnel. And there should be for the actual prescription, I mean, probably the best person are physical activity experts to prescribe the details of doing of the prescriptions, what forms to do, which exercises to do, how many times per day. This can easily be done by anyone else who is trained in physical activity. The nurses could do follow up some basic indicators like a physical duty diary can be followed up by the nurses or psychologists or that same physical duty expert. But then there should be like regular visits as well that involves the physicians, so to see how it goes. So I mean, it's a delegating of tasks, but I think the first visit, I think it's good if it's a physician. I mean, if it's possible.
Mm. Yeah, I like the approach you presented. So, what should be done to be able to implement this on a wide basis in different countries? How to actually do it?
Hmm. It's probably first convincing these countries or the professional associations on the importance. Like I said, in the US, the American College of Sport Medicine, which is an association well respected, they sort of made a brand mark of it. I mean, a trademark and a brand, and they training physicians about it, and they started also to set up groups in different countries about the program and the training it. So um, it's probably just the increase in convincing the professional associations in the different countries of the importance, offering the training through physicians, I mean, either through some associations, institutions, and trying to convince more people to set it up. The other thing is, it should be linked maybe with clinical practice guidelines. This will help it as well because feasibility is one important factor in the prevention of diabetes, but also in prevention of hypertension. And it's a sort of one of the treatment of most chronic diseases. So if it's linked with the guidelines, if it's visible that there's evidence-based, um, there's evidence of systematic reviews and meta-analysis that this works, then it should be entering the clinical practice guidelines. Once we have it in the guidelines, it's a little bit easier, so people know that this is sufficient, this works, and then we have to tell them how to implement the guidelines. The other thing is having it. Some countries have national guidelines on physical activity, so there's another concept to um, having this like the guideline committees are implemented or included in the national guidelines of physical activity. I know that, for instance, Paraguay, Colombia, they have and Argentina, they have national physical activity guidelines, and in some of their guidelines, the prescription of exercise is included.
Hmm. So you said that the physical activities should be in the clinical practice guidelines, that it would be easier then to prescribe and use it as a tool. Why is it not there? There's a lot of evidence of the benefits of physical activity and very little side effects, especially if you're healthy or your heart is checked. So why is it not there already?
It that's a good question. So it depend. It also depends a little bit. For instance, in the U.S., in the American Diabetes Association, they publish every year the standards of care, and physiotherapy is in there. I mean, there's a specific paragraph that says that physiotherapy, like moderate intensity, half an hour, physiotherapy is needed to prevent type 2 diabetes. Evidence A, so the best evidence. So it's there that we should practice it, but unfortunately it's not that much about the physiotherapy prescription. So this, I'm not sure, probably has to do with the people who organize the guidelines, that there a lot of times there may be too much clinical based, so there are a lot of clinicians that work on the guidelines. They do not have maybe a specialty in epidemiology, or they don't maybe see the public health relevance, or they're not aware of it. So this should probably, some political lobbying should be done by the institutions that work in physical activity in each country, and to encourage the professional associations in including this in their guidelines and organizing training, because I mean it works. And as you said, there's not much, I mean, contraindications, there's not much, I mean, side effects of physical activity. The other thing on that, it's a little bit sad that nowadays if you have to ask the physicians if he can be physically active. I mean, who would have thought that about 100 years ago that before physically active, ask a physician if he can move. So it's in general we went to the wrong direction, because this should be like a natural habit to do it. The same is
Hmm.
like getting operated not to eat that much. I mean, about 100 years ago, I mean, people thought that's a joke. But this is where we are nowadays. So I think it's about implementing it and getting it to the guidelines has to do a lot with lobbying, probably from public health perspectives and associations working in physicality.
Hmm. Yeah, when you talk about political lobbying, do you see that the pharma companies has their lobbying here, that the physical activity is not there?
I mean, they're probably not really fighting against physicality, as my experience with working with some pharmaceutical companies in diabetes field, they actually very open to the lifestyle changes as well, and they start to implement them as well. But they're probably more focused on the lobbying on certain medications. So that's what they're driving them, and they are well organized. So we could take an example how they organized, how they do the lobbying, and in also in lifestyle changes. So if you would use the same approach, we probably could be more efficient. But it has to do also with financial probably possibilities in doing it. It's like it's more getting heard. I mean that we're getting heard that this is important, this helps as well, and that for instance diabetes prevention, if we are half an hour physical active, losing 5% of our increased weight, then this has a bigger impact than probably most medications, because it reduces type 2 diabetes by about 40%. It decreases hypertension, it decreases the risk of heart attacks, of cancer, of a lot of different things. It decreases your cholesterol level, increases the good cholesterol level. It decreases blood pressure in general, 2 hour glucose, fasting glucose. So it has so many, and your triglycerides. So it has so many positive impacts that no drug cocktail will do the same changes. But probably maybe for the patients, it's easier taking a tablet or two than actively being physically active or something. I think it needs
Mm.
to change how we think, probably.
Yeah, that does make sense.
This podcast is sponsored by Fibion. Fibion is an accurate sitting and physical activity tracking device and analysis platform. It is a great tool for projects that aim for behavior change in sedentary behavior and incidental physical activity. Fibion provides easy-to-understand PDF and web browser reports for participants. Other features include comparisons to recommendations, linking results to health risks, achievement cards, and interactive goal-setting tool. In addition, Fibion provides an API that allows for easy integration to other systems and applications. Learn more about Fibion at fibion.com/research. Fibion, from researchers to researchers.
So how do you see the role of different digital tools, apps, trackers in the behavior change and physical activity prescription?
I like it. I mean, I use I mean personally, I have a Fitbit, so which I got as the present of as Father's Day present 2 years ago, and then for me it helps. Like when I go running or do sports, it helps me tracking. It's interesting to see where I run. Like you can see, most apps can tell you then the distance you run, the speed you run. It helps you to improving. It controls your heart frequency, your heart rate. Some of them even have sleep patterns. Some apps tell you more or less just about steps you took per day, and it has been shown that for instance 10,000 steps per day is more or less half an hour physical activity. So it's not perfect, but I think it's a very useful tool for patients or regular people or even athletes to follow up their physical activity behavior, and I think it's motivating as well. I mean it's great to see after a workout, okay, how did I perform? What's my resting heart rate? When to reach the peak? What was like the when was aerobic activities, and when there was like fat burn, whatever. I mean, I personally I like it, and I think it's of help for patients to start being physical active, because if you put any app or any device, then usually you forgot about the device. I mean, and automatically get recorded your physical behavior. You can download the data. Your physician or physical expert could download the data, and you can see how you perform and if you improve. Because if your heart rate, your resting heart rate goes down slowly, you do something well. And then if you see that your speed or the intensity of facility goes up or remains the same, I mean, it helps a lot for tracking. So I think it's a very useful, very important tool. And I think if this could be implemented, or even if healthcare insurance company would support that, like certain tools, I think it has a motivational approach, and for the control and for supervision, and a lot of like I think it is of very high importance in prescribing physical activity.
Mm. So how do you see like these consumer devices, like you said, Fitbit? they are good for motivation, kind of empowerment. Do you see a role for physical activity tracking that the medical practitioners could measure accurately the base level of physical activity for the prescription?
I think it's very useful. So what you need to do is probably giving first the patients before you do any changes, like putting him any tracker for some time for a week or two to measure his activity levels, when he's active, what part of the day, what are the intensity level. You measure basically by the increase in the heart rate. So how much time per day he spends like in low levels, a low intensity or moderate intensity level, then to see how he responds to change in visibility. I think it's a very useful tool to assess the baseline levels. And then during the prescription phase or when he starts to be active, it's good for controlling. So you don't need a physical activity diary afterwards because the patient doesn't have to write down anything. So you just download the data of the device, and if the patient agrees that the physician has access, then you have the perfect control, and then you can make changes in the intensity. You can see, okay, you don't reach really the moderate intensity yet, so let's increase a little bit, or here I think it's too much, be careful if you get to the extent like the maximal heart rate, so don't overdo it. I think it's a very useful tool for feasibility monitoring and prescribing.
Mm. And how do you see in medical practice, for example, with the elderly people who are not very technologically savvy? Uh, do you see that every patient should have their own tracker, or would the medical center have them, and would they give devices? So how do you see the practicalities with some patient groups?
Probably it depends a bit on the device. I mean, the beauty. I mean, I personally like numbers. I like to control. I like to track. So I think for like depends a bit on the devices there are. Like for instance, I know Finland had a Polar Watch, the Fitbit, things that the patient don't have to do anything, just to wear it. And especially older patients that are maybe not that aware of technology, it's easy to just wear a certain device which records automatically the data, and they just give the permission to the healthcare person that can use the data, download it. So it helps a lot for the physicians because probably when they have to record or write down when they're active, how much they're active. It's not that accurate, it's not that precise. But if they have a device and don't have to think about it, and the physician have all the data, I think this solves an issue. Of course, if it's data transfer, you need data security and probably make sure that there's not that personal identifiers. But I think the role is specifically in patient groups that are not vegan technologies can be really important. In other groups, I mean, if you use certain apps, apps are good if you have a smartphone. I mean, more and more people have smartphone. Also, the older population has smartphones, and they may should be trained. Maybe they just are not interested. It makes it difficult for them. So then apps are a little bit more difficult. But it's if it's a device they don't have to do anything, or an app that traces their behavior without them having to do anything, that's probably easier to getting the information. I mean, the idea to getting information is it to adapt the physicality prescription or the advice that they have the maximal benefit, and to identify if we see that they overdo it or there's some adverse effects maybe. For younger people, probably it's a motivation. I mean, for me, personally, it's a motivation if I can track my physical behavior during the week. And some of the devices to give you like badges that like now you walked the same distance as like the island of New Zealand is long or something. So it's fun. I mean, it's motivating.
Hmm. And so you mentioned the data security things, and there's quite many things that need to be considered when you would bring these to medical care in a for wider use. So what would be an ideal tracker for for the medical practice use that you could envision?
I mean, there are a lot of different devices. I mean, probably any device that records the patient's heart frequency, that records when the patient is active, that reports like the duration of his activity during the day is useful. So then, if healthcare systems use electronic records, as most European countries using and here as well, then this could be maybe linked with their health records. So you ideally it would be something that downloads the patient data. I mean, online, or there's an automatical backup where the patient gives the permission, download the data, that enters directly the health records, and then there will be sort of a summary statement telling that patient he was translate the message to make it easier for the physicians, that the patient was overall had maybe 100 minutes of moderate visibility during the last 7 days, maybe 50 minutes of vigorous activity. His heart rate was between these limits. On two occasions, it exceeded the maximal frequency. So, sort of maybe alerts or some marks that tells the physician if the patient is does well or not. It should be somehow easy understandable for the physicians, because they're not all physical activity experts. So there has to be translated a message that makes it clear to the physician that the patient as well, where he has to improve, where he has to decrease, what changes has to be made. And if this information can pop up like in one box or one screen, we have all the information, and you can see it in about 20, 30 seconds, gets the most information. That's probably most efficient, given that the limited amount of time some physicians have for the patients. So I think that's probably the challenge, and to program that. But this will be really useful in clinical practice.
So it should be key message that you can understand in, let's say, 20 seconds. What could be the
Yeah.
message? Is it about increasing moderate intensity or decreasing sedentary behavior, or could you give some examples?
What I would imagine, that you have sort of a box that tells like the amount of moderate visibility the patient had during the past week, and then sort of indicates like maybe can be in a red box, sort of missing 20 minutes or exceeded by 20 minutes. So to know whether you need to encourage the patient to be more active, and then you would have this for low intensity, moderate, and vigorous intensity. And then you would have an information on the heart frequency, heart rate frequency, in which occasion he exceeded the maximal frequency, which isn't a good thing. So there's not that much benefit. So that it tries to be an aerobic thing. So probably four or five key indicators that the physician could use what he needs, because he all know he needs to use like if you reach the recommended level. So how many minutes, what was the intensity, and if there are any red flags. So like maximal frequency, I mean overload sort of. So this will probably help. And then he could also use information to write down the patient history, but there should be a specific paragraph about lifestyle, that patient has sufficient physical activity, has nutritional changes done or whatever. Maybe for some specialities, like maybe endocrinology, deal with diabetes patients and physicians that are maybe more aware of physical activity, you could have maybe a more advanced version. So it could be like a basic version for most physicians. And then you may program it if you want more information. You sort of select certain indicators as a physician that you would like to follow. But there's a minimal of four or five main indicators, and then you can select more if you're more interested in. This may help. So
Yeah, no, I like the idea that it would be integrated to the electronic medical records, and that the take home message is very easy and it's quick to check. I like the idea. So how about if we move to another theme, and the pandemic in the world? So how do you see the importance of physical activity at the moment in the world?
the important. I mean, it's as important as before. It's still important to get to the recommended levels of physical and be physical activity. What has changed probably now? It's more difficult to practice what you did before. I mean, I personally I play tennis and I like to play tennis, but all the tennis clubs are closed. So I had to find different forms to be physically active. Then it depends a lot on the quarantine measure the country has. So we have, for instance, on phase zero, which means that we should basically stay at home, but we can go out to shops. And as I have the possibility going for running, so now I started to go running every other day for 40 minutes, so to go jogging. And then in the backyard, I can do some muscle strength activity or using the wall of my backyard to do some volleys and tennis or something. So a lot of people maybe don't have the possibility or they cannot leave home. So some people have some home devices, but usually a lot of people have home devices like a treadmill. They don't really use them. There's a lot of in online tools available that give you, I mean, I found web page for CrossFit that give you exercise you can do at home. These tools are probably important, but I guess it's more difficult to motivate people doing some physical activity exercising at home. I mean, also my personal experience, it's more difficult that I start doing push-ups at home than if I go outside or somewhere. And it's probably the biggest change in COVID is probably the forms or the practices we do in physical activity. So it's not anymore playing soccer, football, or tennis or team sports. So it's more individual sports that people should practice. And if you're a team player, then it's very difficult sometimes changing it, doing some individual exercises. The other thing is, if you have family at home, it's sometimes not that easy to do physical activity when the kids are around or family. So it's not easy. The challenge is that we still will get to the recommended levels of physical activity per week. And I assume that a lot of people have decreased their physical activity levels. We are planning to conduct a study within the next couple of weeks or months on people working at my university. With a questionnaire, we'd like to assess their changes in physicality before the coronavirus and now during the coronavirus. So I hope we're gonna have some information on their habits and their changes in behavior.
Mm. And in US there's quite a bit of people with pre-diabetes and type 2 diabetes, and it's also sedentary behavior is affecting that, and people are probably more sedentary when they need to self-isolate. So how do you see the people with these conditions now?
Hmm. There's probably a lot of different, I mean, problems related to that. First of all, as we are most time inside, our screen time increased. I mean, we're more in front of the TV and more in front of the computer, probably watching more series, more TV. So I think sedentary time probably has increased in a lot of people. If you're already sedentary before, it doesn't help. And if you have obesity, as we usually, when you watch TV, we are eating something, so we're snacking or drinking something. So I don't think it's a very positive impact the COVID on obesity or overweight indicators. The other problem is probably for some patients with chronic diseases that what we have observed in the US is the less people looking and going to emergency room with heart attacks and different symptoms because people are afraid going to the hospital because this is basically where probably the hotspots are where you have a lot of a high risk getting infected with the coronavirus. So it has also an impact on the treatment. That's probably, I guess, the treatment indicators. I could imagine they go in the wrong direction, and we are in related to that. We are planning another like a grant proposal at the moment, trying to assess the changes in the population or certain type of patients after COVID on their treatments and follow up. But I think it's not a good time probably for people being more physically active due to the restrictions they have.
Mm.
This podcast is sponsored by Fibion.
My name is Dr. Paul Batman, and I'd like to just say a few words about Fibion. I've used it a number of times on different projects that I've been involved in and find that it's incredibly reliable, very valid, and incredibly sturdy. I love the graphics that come with it. It really is very clear and can easily see the active in and active periods as well. So I'd certainly recommend Fibion to anyone that's interested in finding out more about sedentary behavior, particularly the concept of sitting and how we can possibly break it up with some really good, valid information.
And you have done work related to hypertension, and it seems that even a hypertension increases the risk of mortality when you get the coronavirus infection. Do you have any take on that? Why is it like that?
Yeah, I mean, when you check the data, the scientific data at the moment, I mean, check who has more complications, who at high risk of death. They're usually people that have hypertension, heart disorders, heart diseases, that have type 2 diabetes, chronic conditions, they're at higher risk. And there has been a lot of different hypotheses, and some studies showed that the one of the main reason is the coagulation factors that coronavirus leads to thrombolytic effects, that basically obstruction of the blood vessels, and some of them die to heart diseases. But if you have an underlying conditions, your basic health is already worse, so this most likely has an impact. And even these people, I mean, if they probably have better controlled lifestyle factors like physical activity, a normal weight, they much better off, have better controlled diabetes, better controlled hypertension. Then I think their prognosis is better than they have uncontrolled hypertension or uncontrolled type 2 diabetes. So again, the importance to having your chronic disease very well controlled in during coronavirus times and even outside the coronavirus times.
Mm. So having the conditions controlled well helps. How do you see the role of physical activity in controlling the different diseases?
It's very important. I think it should be one part of the pillars of the treatment, an important part of the treatment on all chronic diseases. I mean, if you have a disease, it has been shown that physiotherapy should be or is part of the treatment of patients type 2 diabetes or with diabetes. It should be part of treatment of patients hypertension, of heart diseases, because usually if you have had a heart attack, you start rehabilitation. You start on the treadmill, you start to move, and it's important. It helps you getting your physicality levels back, having good health, and in their re I mean to in the rehabilitation of the disease. Of course, after heart attack, you need to be well controlled. How much can be active and slowly increase? So definitely need an expert in rehabilitation medicine to know how much it can be active. But in almost any diseases, physical activity is one of the treatments that should be offered additionally to medical treatment, I mean, drug treatment.
Mm. And how do you see that now with the current levels of infections, for example, in the US, and that the vaccine will take probably at least a couple of years to come? Quite many people with chronic conditions will probably get the disease at some point. Do you see a role of rehabilitation for them, that they would control the disease better, and how this could be done?
I think everything. The problem is there's so many things we don't know yet about the virus. So in general, what we have been observed until now, if people have a chronic disease, the most important thing is they're well controlled. They make sure that their hypertension, their blood pressure is well controlled, that their diabetes is well controlled, the glucose level well controlled, and this reduces the risk of severe complications. So it increases their probability of do not have like adverse health outcomes. I mean, it doesn't give a guarantee, but it definitely increases the odds or the probability. And that's why they should take that opportunity and make sure that if you have high blood pressure, you have diabetes, any other chronic conditions, that you have it well controlled. Physiotherapy is one of the ideal measures that helps you getting these indicators controlled. That's why try to be physically active. I mean, even during the coronavirus times, to get or increase it to the amounts you need to be of better health. If you have better health conditions, your prognosis improves. Of course, you still have a worse prognosis than if you do not have any chronic disease. The same with age. I mean, if you're older, then you have a higher risk of adverse effect of the coronavirus than if you are younger. I mean, but if you're young, it doesn't mean that you have zero risk. You have an increased risk, but not as much as probably people with chronic disease are of older age.
Mm. So we have now discussed physical activity, prescription, its implications to COVID-19. Is there something you would like to add to these topics, or is there other topics you would like to bring into discussion?
No, the only thing is the importance of having a national physical duty guidelines, like on a ministry, health ministry level, or of public health agency levels in the different countries, because not all countries have like national guidelines, and these guidelines should include not only, I mean, of course, one is like the prescription or the way how much should be physically active, but the other thing is, okay, how what has to be changed? You need to have the environment. You have to have like education, physical activity at schools. You have to guarantee that the children have physical activity during enough time at hours during the schools. That the places where people practice physical duty, specifically in South America, are safe, that there's lights, I mean, that there's enough investment, maybe from healthcare insurances, maybe reimbursement if you go to the gym. There's a lot of different environmental factors to modify. And if there are national physical duty guidelines, they maybe lay the ground to ease the access to physical duty for most people, like bicycle roads, for instance, and many other like the built environment, or even how you build cities, that we have certain guidelines that help us to be physically active. And there's a lot of different interventions have been shown that they work. And I think that these national guidelines should be developed and maybe be country specific, but implemented in all over the world. This will probably help from the public health perspective to be more physically active.
Yeah, I like how you bring your international knowledge of different countries into this. This. So, is there anything you would like to promote, or are you looking for any parties for collaboration?
I mean, I'm also interested. I mean, if there's anyone who is interested in taking up doing some studies on the physical duty prescription, or is interested in organizing workshops even through Zoom on physical prescription anywhere, if it's in Finland or anywhere in the world, I mean, feel free to contact me, and I'm sure you can facilitate my email address with people interested in. If you need any advice or interested in more detailed experience on national physical duty guidelines, also I'm more happy to help. The most important thing is, I mean, a message basically to everybody: try to reach like the 150 minutes of moderate physical duty levels. You can do them even twice per day, 15 minutes. It works as well, as it don't have to be 30 minutes in a row. And especially during the coronavirus time, try to maintain or increase the physical duty levels to meet the guidelines, to maintain a good health, and to control your basic disease conditions if you have any chronic diseases.
Mm. So, if anyone interested with collaboration, please be in contact with Noel. So, I think we are closing our time limit. So you will have a short break before your teaching
Thank you.
start. What would be your final remarks for this interesting episode?
Basically, enjoy physical activity and make it do it a form that you like to do. So find out what it is you like to do most. If it's walking, if it's like in Finland, winter cross country skiing, or in summer go jogging, or doing beach volleyball, whatever. I mean, enjoy physical activity, and it's the easiest way probably to reach recommended levels. So it shouldn't be like you be forced to do physical activity. The idea is that you enjoy what you're doing, and physical activity really has so many health benefits on your mental health, on your body, and it also it's a nice social way how to have social contacts and how to meet people and to enjoy life. So I think at least for me, it gives me a lot of energy and helps me going on through the day and to be physically active. And sometimes doing physical, if you go running, walking, you can walk fast, which is also a good form of physicality, and probably the cheapest form of physicality. Go for a walk, for half an hour walk with walk fast, a brisk walking. And it's sometimes I have some nice creative ideas for my work. I mean, a lot of good ideas or bad ideas I have for my work comes when I'm physically active. So it helps me to relax. So try it. I mean, you won't regret it.
I couldn't agree more with your words. Very, very good points. It was an honor to have you in the podcast. It was interesting to hear your very international journey around the world. So thank you for taking the time for this podcast, Noel.
You're very welcome. It was a great experience. And hello to everybody in Finland and everywhere else. So thank you.
Thanks for joining us this week on Physical Activity Researcher Podcast. If you like the show, make sure you never miss an episode by subscribing or following the show on Twitter. This podcast is made possible by listeners like you. Thank you for your support. If you found value in the show, we would really appreciate a rating on Apple Podcast or whichever app you're using. Or if you would, in a real old school way, simply tell a friend about the show. It would be a great help for us. We have a fantastic lineup of guests for forthcoming episodes, so be sure to tune in. Thank you all for your support and have a great day.
This podcast is sponsored by Fibion. Get scientific validation and learn more about Fibion at fibion.com/research. The Physical Activity Researcher podcast has created an activity tracker purchase guide for researchers. Get your free copy from the link in the podcast description.
Thank you for listening to the Physical Activity Researcher Podcast.